I would love to give a brief introduction to today's speaker, Dr. Kenneth Proefrock, which I'm pronouncing now correctly. So Dr. Kenneth Proefrock graduated from Southwest College of Naturopathic Medicine in 1996 with his doctorate in medicine and specialty training in sports medicine. Prior to the Naturopathic Medical School, he received degrees in both chemistry and zoology from Northern Arizona University and worked as research and development quality assurance chemist for Procter Gamble. For the past 25 years, he has conducted a very busy naturopathic medical practice in Surprise, Arizona, and for the past 14 of those years, he has been focused on the clinical aspects of neurological injury and the development of innovative and customizable interventions using autologously derived materials. He is also the current president for the North American Board of Naturopathic Examiners, the chairperson for the biochemistry portion of the Naturopathic Physician's Licensing Exam, and lastly, co-founder and current president of the Naturopathic Oncology Research Institute. So without further ado, welcome to the stage.
Good afternoon. So being the last guy on the stage has a number of kind of caveats to it, one of which is that you're following Dr. Harch and Dr. Crawford, and they're kind of hard acts to follow because they did a pretty phenomenal job. The real heroes, I think, of the day are the families that have children that have neurological problems, because we understand that this is an overwhelming process. It's an overwhelming element of life. It's kind of like in the world of things that you expect might happen. This is kind of the worst case scenario for a lot of people. And so, as Dr. Kaufman had said earlier, we are doing a good job of keeping kids alive who've had brain damage. That means that a lot of the quality of life issues that come along with that are becoming more and more important. We've got a large population of kids who have had neurologic damage and really desperately need some kind of a different level of intervention. I've been teaching neurology for a little less than 20 years, and in 2 decades, at least as it pertains to pediatric neurologic issues, the textbook started out paperback and about this big, and now over 20 years it's become this big. We know a lot more than we used to know even 2 decades ago, but the amount of interventions that we have from neurology for those situations, we're like this and are like this, right? Because nothing's changed, really, despite the fact that we have a greater understanding of what traumatic brain injury, anoxic, hypoxic injuries really involve. So part of, as we talk about things, I'm going to kind of roll through some of these slides, and we're a little bit off on our timing, but I doubt we'll make up any time. So we'll try, though. Interspersed through here, my kids and I and my wife, we live on 10 acres in the Arizona desert, and we have a menagerie of creatures. So here and there, I've peppered it with different creatures that reside in our yard. This is Tommy. She's 54 years old. Every year, she produces 4 or 5 new baby desert tortoises. So I'm in Phoenix, Arizona. We're in actually Northwest Phoenix area. We have a multidisciplinary clinic, and as we talked about in the introduction, for the last 14 years especially, I've been solely devoted to kind of neurological things with pediatric patients. Prior to that, originally I was seeing professional athletes doing concussion clinics around, and then that's kind of where a lot of the therapies that we were driving ultimately came from. Is here you have a population of people who have a surplus income, let's say, and they've hurt their brains. And so imagine being like 25 years old, having several $1 million in the bank and not remember your name in the morning when you woke up. And so that's sometimes what the situation would entail. There are 4 of us in the office, and we see quite a broad range of patients. We deal a lot with patients with cancer, patients with autoimmune diseases, and then, of course, neurological conditions. So the thing that we're here to talk about really are brains, right? And brains in children. And the truth is that this is one of the most complex structures in the known universe. And this is ultimately the original quantum computer. We are a living miracle, every single one of us. Neural architecture goes through a process of flushes of growth and then a culling away of some of those cells. So in the flush of growth, when you have neural remodeling, the sensory information coming to you from the outside world is what establishes that a certain neural connection is going to stick around. If you don't have that sensory input coming from the outside world, then what you just flushed and what you just connected may not stick around, which is why things like therapy, constant interaction, these are important elements to proper remodeling of a brain. Just to step into the weeds just a little bit, to talk about some of the specifics of how brain remodeling happens, it is that neurons are a hollow tubular structure that carry current across them. Because they're a soft, fleshy structure, pushing current across them tends to damage them potentially. It's also what consolidates them. So these microtubule structures they grow and they disassemble. They grow, they disassemble. They grow, they disassemble. At the very end of the neural shoot, you have lots of possibilities for what could become an axonal connection or a dendritic connection. But the current that is allowed to go through those is what actually stabilizes and consolidates the physical structure of that microtubule. If you didn't get the current, it wouldn't stick around. That's why the sensory input is so critical. During that neural growth spurt, axons and dendrites explode, and again, it's the sensory information that comes back that fine-tunes this process, this circuitry, that determines what's going to be kept and what's going to be pruned. We harp on this again and again and again. A lot of my population of patients are kids on the autistic spectrum. And we have families, one family in particular that brought their 15-year-old son in who's basically living in the pantry and he's living on cold cereal and watching TV all day long. And the parents wanted to come in to try some therapies. And what they wanted was some medical marijuana because sometimes he has fits and he's the biggest person in the house and he's going to hurt somebody. And the dad's thought was, well, if we have something like marijuana on hand, maybe we can calm him down. I said, it doesn't work like that. So this reciprocal dynamic develops that is related to the sensory nerves deep inside as they contact the environment, as your sensory system contacts the environment, as that information comes in, it's what determines what you are gonna be like. How each area of your brain ends up getting shaped. If you sit on furniture, your body will conform itself to the shape of furniture, right? Wolff's Law, Dr. Kaufman earlier had talked about that. Whatever you do, we are the most adaptable creature on the planet. We live places that no other creatures can live, except cockroaches, and they come with us, because we can environmentally change where we live, and we can behaviorally change the way that we respond to the way we live. We are endlessly accommodating. We used to think that there's a point where your brain doesn't remodel anymore. And then recently, a study was done on 80-year-olds and found that they remodel their brains just as fast as anybody else. They just don't do that much new stuff, so there's no net change in the remodeling process. So on the edges, the peripheral range of new neural growth, this is where we recognize that a sense of consciousness, a sense of self sort of resides. So when you have damage to those external areas, in a sense, a person can literally lose themselves. So in a lot of cases, what we're trying to do therapeutically is help a person bring themselves back to themselves. Quality architecture is dependent on the raw materials that go into making it. And an important consideration is that about 90% of your brain architecture is in place by the time you're 5. Now, you will constantly remodel that architecture. However, that's an important crossing point because before then, there's ample space available in the nervous system for neural architecture to remodel itself. After that time, the space becomes more and more limited just because the space was filled with that original neuronal remodeling process. So things like pressure. Dr. Harch was talking about hyperbaric oxygen. Pressure can be helpful, pressure can be problematic, right? So if you have a head injury and you swell and you have a reperfusion injury, that causes more impact on neurologic richness. That's Bandit on the right. He's a ring-tailed lemur. He loves craisins and raisins. So one of the things that we use quite often in terms of a therapeutic intervention are autologous therapies. Autologous just means that we derive something from your body and we put it back into your body. We're just reallocating a resource. It's somewhere where it might be in storage mode, and then we're putting it into an area where it could be utilized a little differently. So all you're doing is reallocating resources. It's not a new idea. Autologous therapies have been used since the 1800s. The idea being that you are putting something into somebody that is from them, so there's no risk of a rejection, there's no risk of harm. In the US, we've established some interesting regulatory controls over things that we might use therapeutically. A lot of other countries haven't, and so their particular progress with certain autologous therapies is a little more advanced in certain ways. We're trying to change those regulatory elements, and we'll talk probably more about that. So autologous materials, really anything you could imagine represents an autologous material, from plasma, platelets, bone marrow, immune cells. Essentially, what you see on the right is a depiction of a spun-down blood sample. Nothing creative there necessarily. So one of those autologous therapies is something called a platelet-rich plasma. So I'm going to say right now that the use of the term platelet-rich plasma is sort of a pretext for us for things that we do with people's blood. We don't have the terminology, and we don't have necessarily the regulatory input more than to say that PRP exists. Nothing else really exists in that regard. So essentially, the idea is platelets contain a platelet-derived growth factor. If you hurt yourself, if you cut yourself, platelets are going to migrate into that area, and they're going to be involved in stopping the bleeding, but they also bring with them some growth factors that are pretty critical for the proper healing of that tissue. And so when we make a PRP, traditionally, we're making something that is a platelet-rich plasma, trying to access those platelets. There's a lot of debate as to what constitutes a PRP and what doesn't constitute PRP. For your purposes, who cares? For my purposes, it's a tool. It's a vehicle for being able to adjust and alter how an immune system is monitoring the body, how, especially in autoimmune conditions, or how you might be able to supply resources to a damaged area so that it can then heal more appropriately. So one of the essential elements of PRP is that you're stimulating some inflammation in an area like a joint in order to get that structure that you've just injected that into to heal more appropriately after some injury. We don't want inflammation. That's not going to really help us. But the plasma itself becomes a great vehicle for being able to introduce other things. So PRP, it's a crude cell separation technique. It's just the way we name something, ultimately. So what you do get, though, is a whole lot of pretty interesting things when you take a sample of tissue from somebody. We're still talking about blood, but other tissues have a similar makeup, but we'll talk about that a little bit more in depth. And so what's critical for our purposes is this little white area here, which is called a Buffy coat. A Buffy coat is the concentration of white blood cells in a blood sample when you've spun it down. In that Buffy coat, we've got all kinds of goodies, which are CD cells. CD stands for cell differentiation. We say we're differentiating these cells, and we're putting a number beside them because they all share a receptor. They do the same things, or they look the same, or they'll bind to the same substrate, is basically how you determine that. It doesn't speak at all to what their function is. In the case of a natural killer cell, these are immune cells. They are surveillance cells. They help eliminate cancer, things like that in the body, as well as new infections. B cells help your immune system create antibodies to particular things, as you might need that. In some cases of patients with autoimmune conditions, we might capitalize on those B cells because CD19, which are a programmer of B cells, do tend to help us dissuade autoimmune tendencies. So that's how we get people who have lupus or rheumatoid arthritis to teach their immune system not to attack their own tissues anymore. It goes beyond the scope of our conversation today, but just to say, it can be a really great tool. So what magic is it turn it off and turn it on thing when it doesn't work? Oh, don't push it 30 times. So what's been well established over a long period of time, and then we also get, depending on the country you're in Canada, we'll get full reimbursement for a PRP treatment and somebody for a musculoskeletal condition. In 2015, using some stem cells and some PRP, we did a large study of 1,422 patients where we showed that there was a 92% improvement in musculoskeletal dysfunction as a result of this plus mesenchymal cell derivative, which up to this point is the biggest study that's been done that way. It was our clinic in collaboration with a clinic in Switzerland and a clinic in the Czech Republic. The point is here that this is a pretty well-established technique for helping to stimulate healing in a body. The beauty of it is it's all yours. I mean, we can add some stuff to it, like people really appreciate it if we add something like procaine to it so that it's not so painful. And then we generally do that with a scaffolding element, which we'll talk about. I'm resisting the urge. Okay, well, hey, and then in 2009, this study came out, which we'd already been using some PRP-based elements for central nervous system dysfunction, and we'll talk about how exactly we would apply that. But this pretty interesting study came out, which showed that it was a potentially effective novel treatment for central nervous system diseases. Essentially, some of the diseases that they looked at were neurodegenerative conditions, but what was really fascinating was in its use in traumatic brain injuries. We're going old-fashioned now. It's just a nod. It's a wink and a nod. What's in PRP? Well, there was that fraction, but there's a lot more in PRP. And this is a heavily studied arena, right? Now, heavily studied, not really in the US. We are a consumer society. We buy stuff. We're really good at buying stuff. We have the most brilliant minds in our culture figuring out ways to sell you more stuff. If you turn on the TV, the first thing that will happen is they will explain to you how you are inadequate or your life is inadequate and you couldn't possibly be happy unless you had this or you had that. And so the research that's done in the United States is largely driven by product. It's driven by an industry that's looking to substantiate the use of some new intervention that will be a product because you want to make back the money you spent in your research and development process. If I use your blood, you own that blood, I don't own that blood, and that's not patentable, and it's not something that's gonna garner big, generous donations from large corporations. So in PRP, we have a lot of growth factors. I say that, but it really depends on how you spin that PRP down. For our purposes, what we've done over the last 15 years, 20 years, is we have something called a NanoView, which is a UV-Vis spectrophotometer, and we have an HPLC. Putting human tissue through an HPLC is very challenging because you have to get it down to a 0.2 micron, and there's a lot of proteins in blood. But the UV-Vis will help you, so long as you have the template or the blueprint for that item in the database, the UV-Vis will tell you whether it's there or whether it's not. And it'll give you a rough estimate of how much is there. So these are all things that are commonly found in a PRP sample. Again, it's all dependent on how fast do you spin that sample down and for how long do you spin it. So you have a certain amount of layering that's going to happen in your tissue sample, and then you get to pick and choose which of those layers you want to take out or administer to the patient. Okay. One of those elements, and I'm just bringing up one of them, is something called thymosin beta 4. Thymosins are thymus-derived peptides. We make them, our immune system makes them. You have a very vast lymphatic system. And a thymic gland is a part of your lymph system that lives in your chest. By the time you're an adult, it's involuted. It doesn't really do much. And it depends on your age and the amount of stress that you've had in your life. In one of those interesting side stories about medicine in the 1950s, early 1950s, and by the way, this is documented in Nelson's textbook of Pediatrics. If you can get an old version off of eBay from like 1950 or before, it's this thick. And this story that I'm about to tell you is in there. The new version is paperback and this thick, and it does not have this story in it any longer. So somewhere after World War II, as a result of well, let me back up a minute. You're in medical school. You get cadavers to work on. The cadavers that you get are usually people who are at or below the poverty line, unless it's been somebody who's generous enough to donate their body to science. But generally speaking, if you donate your body to science and you become a cadaver for a medical school, they pay for your burial, or your whatever is going to happen to your remains. So. It turns out that a preponderance, especially of children, of small children who pass away, their bodies get donated to science for this purpose. They were generally, especially around World War II and right after World War II, these were generally people who were below the poverty line and suffered from malnutrition, stressful lives, whatever might have caused their early demise. Because stress causes an early involution of a thymus gland, the idea at the time was, well, here's what a normal thymus gland looks like. And everybody catalogs that in their head. And then we start having this phenomenon in the early 1950s that gets identified, which is SIDS, sudden infant death syndrome. And people would be like, oh, I don't want my baby to die from that. And so some babies who passed away from SIDS had autopsies done, and they found that, wow, compared to those children that we saw in cadaver labs, the thymus glands in these kids is huge. Probably they're laying face down in their crib and that thymus gland is suffocating them. So for several years, almost a decade, the standard of care was to irradiate children's babies' thymus glands so that that would not happen. It changed the SIDS death rate not a bit, and ends up one of the jobs of your thymus gland is to help weed out autoreactive antibodies. It's maturing T lymphocytes, but it's also helping to weed out autoreactive antibodies through your lymph. And thymosin beta 4 is one of the more important elements in that process. You make it every day. Thymosin beta 4 also causes an increase in the amount of actin filaments in your muscles that get made. Actin and myosin are two portions of a muscle cell that when you contract a muscle, they ratchet together and they ratchet apart. With dystonia, which we'll talk a lot about later on, the issue is a lot of times because under the extreme amount of tension that dystonia causes, the kids will get a certain kind of muscle development, but it's not necessarily a functional muscle development. And so thymosin beta 4 just becomes a really important element for helping, when kids have dystonia, start redeveloping a more normal muscular structure so that the dystonia doesn't have to continue on. Some of the things that you'll see here is thymosin beta 4 is secreted from platelets, aids in the formation of crosslinks and fibrin, and we get this from platelets. You can get it other places as well. So, human stem cells. First of all, the FDA does not like that term. Stem cells has become meaningless. It just doesn't mean much anymore because everybody and their dog is selling something they're calling a stem cell. Most of those products are not stem cells. Most of those products are derived from placental material. They're derived from, you have companies like, I'm not going to say companies, but there are companies that will tell you it's one thing. It's really not. For a lot of those products, just for a point of interest to see how concentrated they really were, we would get some, we'd run it on a microscope. We use a hemocytometer, which I'll show you pictures of too, and say, hey, how much cellular material is in here? None. And so we aren't very good, just technologically as a species, at freezing our cells and then waking them up and making them functional. We can clone a sheep because we can do that with a sheep cell. We can do that with a frog cell. We just haven't figured out how to do it with a human cell. So by all means, bank your umbilical cord blood, but at the moment, we don't freeze it properly to be able to resurrect it and actually get some cellular material from it that's viable and can replicate itself. That doesn't mean that it's a useless commodity. There's a whole lot of growth factors. There's a whole lot of other stuff that's in there that is immensely helpful, but it's not cellular, for whatever that's worth. So you have two types of human stem cells, yours and someone else's. If you get your stem cells, your body will incorporate them into your structure. If you get somebody else's stem cells, you're gonna have some measure of rejection. That rejection might be 10%, it might be 100%, but you don't know that. Unless you do some kind of a typing process, like if you're gonna get any other tissue transplant, you would have a typing and you'd have somebody who is a match. Well, if you have a random assortment of cellular material from people that are donors, we have to talk about how the donors are chosen, of course, and how they're screened, but also it's still someone else's stuff. Your body still is gonna have a tendency to reject that. So besides yours and someone else's, there's embryonic cells, which come from an embryo. Still somebody else's, right? Every time you make a cell, let's say your name is Jordash, what do? You tag Jordash on the back of it. You do that through a little ubiquitin protein. You label everything you make with your own tag. If something comes into you and it doesn't have your tag, your immune system says, ooh, this is foreign, let's eat it and get rid of it. If it doesn't have your tag, you're not gonna keep it for that long. Does that mean it doesn't work for people? It doesn't mean that at all. It just means what we need to do is be really selective and clear about what our definitions are, right? What are we really talking about? So the FDA is gonna get rid of the word stem cell. They've even had the fellow who wrote the original paper identifying stem cells and naming them mesenchymal stem cells, MSCs, and they've asked him to retract his paper, which he has done, and he's offered a new name, a medicinal signaling cell. Because a stem cell, Dr. Harch beautifully put it, with a baby, and then he had a list of possibilities of what that baby could become, a dentist, a lawyer, a mother, a father, whatever. Well, to say that a stem cell is like saying to that little girl, you're a lawyer. Well, she's not one yet. You have to prove the point. A stem cell replicates itself into more stem cells and or differentiates itself into multiple tissue lines. How do you prove that? You have to incubate the cells in order to prove that. You've got to put something in place to show that that's really what it is. So, however, a mesenchymal stem cell, that is just a name, right? The change to a medicinal signaling cell does something really important legally, and that is that it makes it so that you've now used a dirty word, medicinal. Now it's a drug. Whether you walked in with it in your love handle or not, now it's a drug because we're making a claim about it. So to call something a stem cell is already misrepresenting things, just from a marketing sense. And this is the rationale that the FDA and the FTC has for the enforcement that they now engage with. We've had a long-term relationship with the FDA. Sometimes it's been good. Most of the time it has not. That's not to say that they've ever sanctioned this, which they have not. We have a local IRB, an investigational review board, who reviews our protocols and what we do, and they are our liaison between us and the FDA. However, that becomes a shaggy dog story pretty quickly. Just know we're in the good graces of the FDA because we don't have a website. If you're doing experimental medicine, you can't advertise. That's their stipulation. So they said, take your website down. Okay. And they said, you can't advertise. So, and they crop up in the most unusual of places. So you'll notice that we don't have an advertisement in the brochure because we don't advertise. You just can't. It's strictly word of mouth. Anytime you're doing patient funded research, that's the way the rules go. You have stem cells everywhere. Their job is, if you get rolled by a bear, then how are you going to repair your liver? Well, these cells are motivated by trauma. They will move into that area, and they will help repair that structure, is the general idea. So a mesenchymal stem cell, they are all over your body. An easy place to get them is fat. When we first started doing stem cell kind of work, or autologous tissue transplants, ATTs. ATT is okay to say. Autologous tissue transplant just means autologous, it came from you, it's a tissue, we're transplanting it from one place to the next. So long as we do that with a minimal manipulation of the cells, which is great. Because originally, we were breaking it down with some collagenase. We were doing all kinds of things to it. And, you know, it was a lot of work. And then they said, no, you can't do all that stuff to it. And you can't put that enzyme in there either. And so we pulled the enzyme out. We started a different way. Yeah, results weren't as good. And so then we kind of figured out, what can we do a little differently? And we'll talk a little bit more about that as well. So essentially, what we started out doing bone marrow biopsies and lumbar punctures. So a bone marrow biopsy is you've got this corkscrew type trocar or trochee that you are winding into a hip bone. You can't numb a bone. I can numb the whole area, but you can't numb a bone. For a child, you've almost certainly got to put them under a general anesthesia in order to make that happen. General anesthesia is a controlled poisoning of a brain. If you don't have to do that to somebody who's already got a brain injury, so much the better. Also, we would put that back in between L1 and L2 in a lumbar puncture. Doing lumbar punctures in kids in the office, that's a sucker's game. You do not want to engage in that kind of thing. It's an anxiety attack for everybody involved, and we didn't love doing it. We needed to figure out a different way to do it. The reason is a lumbar puncture can lead to a leak of cerebrospinal fluid. You're taking 7 cc's of fluid out to put 4 cc's worth of material back in. You're still going to have an increase in pressure. They're going to have a headache. It's going to last 3 days. If you get a leak, you've got to come back in, do a blood patch where you pull some platelets and you stick it in the same hole that you put it into. Hopefully you can still see the hole that you put it into so that you can get really accurate. Otherwise, you're just peppering the whole area. I'm just saying, it's not something you want to do. It's not a good day in the office. When we started doing adipose-derived, like when we do a bone marrow biopsy, we'd get 600,000 cells out of a sample. Like, okay, if you can expand them like Dr. Consuela does in Mexico, all right, you can get that to several million. Great. We can't do that here. FDA says, no. As soon as you expand those cells, you've created a drug. And so we can't do that. So it's like, well, okay. First time we took a fat sample as a result of Patricia Zook's paper, which I'll show you here. Actually, maybe that's the next one. Maybe. Oh, the difference between adipose-derived versus bone marrow-derived, which we'll talk about. The first time we did a fat biopsy, I got 4.5 million cells. Just from a little bit of fat. I was like, holy Hannah, we have hit the mother lode. I'm like, shoot, how much is the possibility? What possibility is there? So, and we'll talk about that. But now we seldom get less than 300 million cells, is sort of the long and the short of that. Do numbers make a difference? Well, maybe they do and maybe they don't. Here's the conversation at my IRB is if you have the capacity for 1 billion new cells, and I harvest 500 million cells and we put them into a system and they divide once and now you're at your billion capacity, are those cells better suited to that environment than say if you got 100 million cells and they had to multiply several times and find niches? Are they better suited to that environment? So it could be that this arbitrary number that we chose, which just seemed to happen to come up a lot, that's the number that we picked out, but it may well be that there's different numbers. And it may well be that if we can figure out how to freeze some cells and wake them back up again, maybe progressive treatments would be more effective. In the future, that might be the case. One of the other stipulations for the FDA is they want homology. They want, if you're gonna do a tissue transplant for somebody, then you should take a tissue that's very similar or homologous to the tissue you want to change, you want to have be improved. That process, what that means is you have to see what the tendency is for that stem cell line to become. Just because something's a stem cell means it can become a lot of different things, but they've got a proclivity to become certain things depending on where they came from. So bone marrow cells tend to become hematopoietic stem cells, hematopoietic, they tend to become blood products, and mesenchymal cells tend to become more connective tissue products. And you get different amounts from different samples. So you can get some stem cells from a peripheral blood sample. It's not a huge amount, but you can get them, and they certainly play some kind of a role. Bone marrow, and then adipose. Adipose we get anywhere from, and 10 to 50 million is kids. I'm sorry, that's adults, the population at large. In kids, we see something more akin to 50 to 75 million cells per gram of fat. There's this interesting proportionality too, which is that the thinner a child is, the more concentrated the cells tend to be in that fat. So when I go to pull the sample, usually if they're super small and thin child, I don't really need that much of a sample to get an adequate amount of cells. Versus somebody who's got a little bit more fat to them, yeah, I'll take a little bit more. And with adults, with kids, we usually get, we shoot for 5 grams of fat, which is about a teaspoon or so. That 5 grams is usually not traumatic, ask the kid, but and then is wieldy, and I can usually get those cells pretty well. With an adult, I usually need 30 grams of fat to get an equivalent amount of cells. And it depends on the adult. If you've had an Agent Orange exposure, we won't get any, which may explain why a lot of people with Agent Orange exposures have long-term disability issues that are so variable. I keep trying the button. I'm hopelessly optimistic. Patricia Zook, Patricia Zook is an unsung hero of medicine, in my opinion. She's currently teaching at a very small private college. She's the one who really blew the doors off of this in 2002, at least for me, she's the one who said, look, and she wrote this paper, deriving stem cells from the fat of mice. I'm like, oh, that's interesting. And she used, so part of it is she used bovine serum to inoculate, to process the cells. I'm like, well, you just use the person's serum if you don't mind, because you can get a lot more blood from a human than you can a mouse. Patricia Zook, we owe a great debt of gratitude to, because she proved not just that the cells from adipose tissue were multipotent, but she specifically looked at them as progenitor cells for things like adipocytes, chondrocytes, osteoblasts, myoblasts, and ultimately we see that with neural tissue as well. When we pull from a fat, we create what's called a stromal vascular fraction. So you pull the fat sample and you've got to process that. The first thing we have to do is we have to extrude it to break up the connective tissue, and then we start spinning it. When I start spinning it, it starts layering out. I get a sense of what kind of material is going to be in that fat, how good is it for our purposes, and what might you have to do to manipulate things. But we call that lipoaspirate. So it's a liposuction kind of a method, which we'll talk a little bit more about here in a minute too. So the stromal vascular fraction basically is the portion of the fat that is cellular. In the stromal vascular fraction, you can have some red blood cells, you can have some white blood cells, and you can have some mesenchymal cells. So when we pull our samples and when we look at it on our slide, I want to see some white blood cells, I want to see some red blood cells, and then I want to see some nucleated cells from that stromal vascular fraction. Nucleated meaning they have a nucleus, right? Red blood cells don't have a nucleus, and white blood cells stain beautifully with something called trypan blue. So we put a little stain on, and I'll show you some pictures of some slides here in a minute. This is the paper that we published in 2015 on autologous derived for patients with osteoarthritis. 1,400 and maybe it's 1,422 patients. I don't remember now. So the FDA wants us to publish a paper. We want a peer-reviewed study. I said, look, the thing is, every kid is different. I can have 10 kids who've had the same exact injury at the same day in the same pool in the same whatever, and they all manifest differently. You can have a set of twins have a horrible accident, and one of them walk away without any problems whatsoever, and the other one is horribly debilitated. So it really defies easy statistical analysis. So we have, for the last 10 years especially, been trying to parse data in such a way that we can say something. So far, we haven't been able to come up with much, although Dr. Harch has he's right. There are 12 patients that we saw consecutively that came directly from his place to our place and back to his place, and we're like, wow, that was a really, really good sample. The first couple times you're like, great. First time you think to yourself, I did a great job here. The third time you're like, all right, this isn't me. Something else is going on. And pretty soon you start noticing the trend and you're like, oh, this whole HBOT and stem cell combination really gets to be dynamic for a lot of kids. That's exciting. I turned this off for a long time. It still doesn't work. Adipose is great, it's easy to harvest. You get 1,000 times more cells than you have in a bone marrow. They're inactive sitting there, but they're active when you wake them up, right? If you go poke a lipoaspiration cannula in where we do the liposuction, you're traumatizing those cells. That's what wakes them up. And you're also waking up whatever white blood cells are in that area too. And what happens when you poke a bear in a cage, What happens when you poke a white blood cell in a cage is they make more of themselves. And they're aggressive. Okay. Let's go beyond that too. Let's go there too. So some of this I've already talked about. So what are the capabilities? The literature suggests that adipose tissue, and there are separate studies related to this process, but specifically the one that, of course, we're focusing on is neuron. Just know that adipose tissue can become nearly any other type of connective tissue in the body. From connective tissue, you have to then help it derive into something maybe more meaningful. Okay. So how do you do this thing? Well, you get a 14-gauge needle, you numb a person up. We numb them up with a gel and a spray first so that it doesn't 100% make people numb. Some people are really good candidates for topical anesthetics, and they get numb, and they don't feel it when I put a needle in to numb them up some more. I've got to still go inside and put an anesthetic in. We choose procaine and lidocaine. Procaine works pretty quickly. It's broken down at the cells. It's a vasodilator, so it gets good dispersion. It just doesn't last very long. Lidocaine stings a little when it goes in, lasts 2.5 hours. So we put the procaine in, we put the lidocaine in, we put them together so that we have a better response, let's say. And then essentially, so what their person's doing up in the upper left hand, that's not the way it goes. The way it goes is you got a love handle right off the top of your hip. We use your hip as a guideline. We're going sideways. We're not going straight up and down. I'm not pulling your tissue up and pinching it and poking it like that. But we are going in and we're going back and forth and we're sucking this fat out. It's a standard liposuction technique. When we first started doing this, I did a little workshop to show some other people to do that. And this fellow, Carlos Vergara, who's from Mexico, and he's a plastic surgeon who does liposuction, says, I'm really interested in what you do. I said, I'm really interested in what you do. I said, if you show me what you do, I'll show you what I do. So there's this whole story, if I give you $1, you have $1. If you have $1 and I have $1 and we exchange those dollars, we still have $1. If you have an idea and I have an idea and we share those ideas, we both go away with 2 ideas. That's a beautiful thing, right? And so Carlos and I have maintained a good friendship, nice guy, and he taught me how to do liposuction. It's not hard, but there are some things you want to make sure that you're doing right. So essentially, once you get the fat, then you take it back to the lab. I do an extrusion process where I put it through a luer lock to luer lock adapter. You have to break up some of that connective tissue just to liberate the cells. You gotta be gentle, you gotta keep it at the right temperature. The clean room is dedicated to this particular process. It's an aseptic technique in the clean room, in a hood. And that hood is dedicated to that individual for that time. So we pull 3.5 to 5 grams, we extrude it to break it down, we separate it with centrifugation, we isolate those MSCs. We get a sample that is readable on a hemocytometer, and I'll show you some slides that we did. Just pulling them out is activating. One of the things we have to do is you've got to put them in something because otherwise you're putting a random cellular material into a place. So we put them into a scaffold. The scaffold is a hyaluronic acid scaffold. Again, we'll talk about that. And then when we administer it, I'm probably getting ahead of myself. So straightforward. We use these falcon tubes because they're see-through. It really makes life easy. Next one. That is Twister. He is our billy goat. So adipose, we like it better than bone marrow because I can make it not hurt. We get more cells and we don't have to culture cells, and there's not any kind of moral or ethical issues. We can numb a person up and do a minor surgical procedure and get that done. So what's in a stromal vascular fraction? So I spin some fat down. What the heck are you getting? Well, what you get is, first off, you get a layer of fat at the top, right? Fat rises to the surface. In that fat is the stromal vascular fraction. In that fat are our cells. We want those out of there. So we want to get them out as much as we possibly can. What else is in there? We have hematopoietic cells. Even in fat, we have progenitor cells, and we have a whole lot of white blood cells as well. And those white blood cells are primo, because the stem cells are bricks. They don't know what they're supposed to do. They don't even know how they're supposed to do what they're supposed to do. They have to have some guidance. That guidance comes from the white blood cells. When we harvest the white blood cells and we incorporate them into the sample, which, by the way, is more minimal manipulation. I just took one less layer off. And so those act as both a chaperone to keep the system a person from getting sick in the process or having any kind of problems because we've opened up a blood-brain barrier, which I guess we should talk about too. But this is a rich supply. In that SVF, we find thymosin beta-4, we find transforming growth factor beta-2, and there's a ton of other peptides and growth factors that are dependent on the individual and dependent on what that individual's been doing. If you're well nourished and you've had some HBOT, we get a lot of really good things that make those stem cells more able to do their job when they go in through the transplant. If you're undernourished, if you're stressed, then this gets a lot more spare. These are actual hemocytometer slides. If you don't know, a hemocytometer is a standard blood counting slide. Most people don't learn how to actually count cells anymore because the laboratory has it with a flow cytometer, which is a big machine that automatically counts cells. Well, we kind of have to count cells, so I've taught my kids how to count cells, and because sometimes you want another person besides yourself counting those cells, because you might know how much work you put into it, how much is needed, and you might fudge the number. Someone who doesn't know anything, they come in and they say, count this, what do you get? That's a more accurate count. Maybe it is, maybe it isn't. Essentially what you're doing is, the slide on the right is a little bit more helpful, but there are 400 of these squares. I have to turn it back on to make this laser work. There's 400 of these squares per 1,000th of a microliter. That's standard. What changes is the depth of the slide. And there's a conversion factor in the slide, which is, for this slide, for whatever it's worth, is 1.79. But that has to do with how deep and how well you can get a single layer of cells. In this case, this is a nice single layer of cells. This is not. These are built up on one another. But these guys that are on top are perfect little stem cells. So then we extrapolate that out. You count up 4 or 5 squares. I multiply that by the 400, by your conversion factor. There's a couple of other factors that have to do with how much volume did you get of a sample at the end, as well as how much of your sample did you use to put on the hematometer, which is a percentage kind of a thing. So this, from there, then we prep the stage intranasally with a couple of enzymes, collagenase and hyaluronidase. Originally, we used collagenase in the process of breaking up the connective tissue. Turns out you don't need to use collagenase for that because the extrusion does that just fine. And it turns out that the FDA considers that an off-label usage for collagenase, and they weren't really thrilled with that. It also turns out that the FDA gave XIAFLEX, a company that sells collagenase for things like Dupuytren's contracture, for different contractures, and they sell it for $3,200 a milligram. It takes me 8 to 10 milligrams of collagenase to do my thing. That's really expensive. The day that they were given that privilege and that right, I asked Cameron, my son who works at the office, I said, just for clicks and giggles, weigh out how much collagenase we have in the freezer and let's see at XIAFLEX's prices what that's worth. It was worth like $880,000 or some crazy thing. I'm like, wow, we're rich in collagenase, except you can't do anything with it, right? Because they've got exclusive market rights. When the FDA gives you that, then, and I'm not selling collagenase anyway, I just use it as part of our system. What we found is that when we didn't use the collagenase for a little while in the process, we weren't getting as good a result. When I started putting collagenase into the pre-prep nasal spray with the hyaluronidase, which is established with some research that I'll show you a paper for, we got back the same kind of results we were getting before. The collagenase was doing something. The FDA was right. There was no way to get rid of all that collagenase from the sample. We were putting collagenase into people. And they're like, what's that doing? Oh, it turns out that neurons don't replicate themselves, with a couple of exceptions. Nasal neurons do replicate themselves. So you can have some horrible thing happen to your nasal passageway and you can't smell anymore, and then they can regenerate themselves because there are nasal neural stem cells. A few years ago, there was an important study that was done at Cornell University for a fellow who broke his neck. And the people involved said, well, what if we took some nasal-derived stem cells from neurons and put them in his neck? Would that help anything? He walked. Cornell University, 7 years ago. We're like, oh, really? I'm not sure what the end result was for that particular patient, but I'm like, I wonder if when we prep the nasal passageway with the enzymes, which open up a blood-brain barrier so that the cells can actually get through, are we roughing this up a little bit and releasing some of those neuronal stem cells from the nasal passageway? We don't know, but we might be. We don't know. 10% of the sample is administered intranasally about 30 minutes after we put those enzymes in. 90% of it is seeded into a depot. It's scaffolded into a hyaluronic acid depot. Hyaluronic acid is a scaffolding material. It is the main ingredient in Wharton's jelly. It supports the cells and it allows them to expand. We put some PRP in with that, or some plasma in, because that's what they feed on, and then they replicate themselves. And as they move to the outside of the depot, they migrate up into the cerebrospinal fluid through a non-pressurized environment. Where do the cells go? If you do them IV, most of them go to your lungs, and a few of them go to your spleen. But they do go everywhere. How many does it take? Here's back to our IRB. What if you got 10,000 of them, of your 300 million that got across the blood-brain barrier? They still do a lot because they sit and replicate themselves. Cells will take up the space that's available to them so long as there are resources available for them to do that, and they'll fill the entire space. They'll even overfill the space. And they home to tissue following chemotactic distress signals produced by injured tissue. And people often ask, why didn't they do that in the first place? Well, they tried to, as Dr. Harch was talking about this morning, those areas in your brain that produce stem cells might have been damaged. They may not be available. And it may be hard for a system to get peripheral body cells back up through that blood-brain barrier again. So when we put the enzymes in, collagenase and hyaluronidase, we're being very specific about breaking down collagen and hyaluronan. It's scar tissue primarily, but you're still disrupting some tissue. That sends a trauma message. Even though it's tissue we'd like to get rid of, it's still a trauma message. That renews the homing response for those cells to move to that area. For kids that are a little bit older, or adults, or after it's been a long time after the incident, the scar tissue really becomes our biggest issue. It becomes a barrier for neurologic remodeling. Nerves can't spark across scars, and scar tissue doesn't conduct electricity very well. So there's a lot of different ways that we think that these cells work. They are medicinal signaling cells. They are sending messages around to the tissues around them for sure. We know that they can differentiate into several different kinds of tissues. They are anti-proliferative, immunomodulatory, and they have an anti-inflammatory effect. Those are all things that have been pretty well established with the papers that are at the bottom of the slide. And I believe you all get a copy of the slideshow. So they're all papers that kind of discuss that. What we think mediates those effects, TGF-beta, some growth factors, and some antagonist interleukins. There's more to that than what I just said. So they also enhance proliferation, migration, differentiation of endogenous tissues. So coming in from another area, if you have some capacity to make more cells, then they will help ensure that that happens. And so the mitochondria become a big issue that we'll talk about near the end of this. Oof. We might be going over time a little bit. I promise it's not going to be that long though. And let's go to the next one. So one of the other issues, especially with kids that have had hypoxic injuries, is their blood-brain barrier gets really irritated, inflamed. The blood-brain barrier's job is to be a selective filter so that some things come across and some things do not, and be able to filter out certain information from the outside world. The purpose of this slide is to show you that there have been a number of studies that have shown there are several mechanisms by which just putting stem cells after some enzymes to open up the portal up into the blood-brain barrier, how that can help consolidate and change that blood-brain barrier and bring it back to a place where it's more functional. So this blood-brain barrier is just this complex multicellular structure, and less than 2% of small molecules are able to cross the blood-brain barrier. It's a big deal, this blood-brain barrier thing. And there's a number of issues that we get from a leaky BBB. People who've had mold exposure definitely have leaky blood-brain barriers. Sometimes we think they might have had that beforehand, and that's why their mold exposure was so much worse than it would have been otherwise. The hydrogels, we use hyaluronic acid because it's very friendly to tissues. The FDA says hyaluronic acid is in the body for 6 months when you put it in. It's normally used as a filler for wrinkles. When we use it as a depot, they say there's no reason for you to do another treatment in less than 6 months because your depot's still present. We have on ultrasound over the years just checked people, and it turns out that that's about right. Some people it's gone in 5 months, and other people it's still there in 9 months. However, it is that depot, we can only count on it for about 6 months. We make it ourselves, the hyaluronic acid, because we can't afford to have it be foreign. Like a lot of stuff is a rooster comb. We can't do that, especially not if we're going to put it in your nervous system. We have to keep it as clean as possible. So we purchase a clean, it's actually a vegan, if that matters, hyaluronate powder that then we make into the slurry, the gel that we then filter and then put into the person. Hyaluronic acid is a very common polymer. It is, like I said, it's the basic ingredient in Wharton's jelly. So the rationale, how do you know if you put some cells up your nose that they'll actually get to your brain? Well, this is a very excellent paper that was written that describes the process. In this case, in this particular paper, they're using hyaluronidase as the primary driver. We did that. So as just a hyaluronidase. It was great. Hyaluronidase is great. And we're going to talk more about that in 5 minutes, within 5 minutes. Really, we saw a lot more changes when we put the collagenase back into the mix. There's something about collagenase. So it is a enzyme. Enzymes are specific. Whatever the name says, and then ACE means it's cutting something up, and then whatever comes before that is what it cut up. So in this case, collagenase breaks down collagen. There's several different kinds of collagen, and it is a proteolytic enzyme. And then there is hyaluronidase, another enzyme that is not proteolytic necessarily, but it specifically cleaves hyaluronan. Hyaluronan is what they call a magic tissue glue. In your tendons, as your muscle attaches to a bone, it becomes a tendon so that attachment is very strong. And there's a sheath, a modified sheath from the muscle that goes into the tendon. That tendon sheath oozes some synovial fluid that lubricates that pulley system. Hyaluronic acid is the lubricant for that process. If you hold that joint in one place for a really long time, the hyaluronic acid no longer lubricates, now it becomes a glue. So for a lot of kids, their neurologic issues will cause a antalgic position. They'll hold themselves in this position. And like Dr. Kaufman had some great pictures, well, sometimes just because they've been in that position for a long time, the brain forgets that it could do something else. The brain lesion that caused that antalgic position in the first place may be gone, or it might not be, we don't know, but if you can put some hyaluronidase into that area, you might be able to change that. So let's go to the next one too. Okay, Dr. Raghavan, who's at New York University in Langone, another brilliant fellow, says, hey, if hyaluronan or hyaluronic acid accumulates and causes things to stick, what if you put a little hyaluronidase in that area? I read this paper and I'm like, I got a freezer full of hyaluronidase. Why don't we try it? So we try it on some adults, football players, they've got long-term injuries. Oh my. It's pretty amazing at opening up areas that have been restricted. Contractures added to collagenase for Dupuytren's contracture, it's pretty remarkable. Breaking up scar tissue, it's pretty remarkable. Let's go to the next one. And so with dystonia is an interesting phenomenon. We all know about dystonia. It's hardcore, right? So the neural mechanisms don't explain it completely. So enter what's called the hyaluronan hypothesis, it's the accumulation of hyaluronan, which normally functions as a lubricant, but also leads to the development of this muscle stiffness. Essentially, the tendon can't slide through the sheath anymore, it's glued. So we've had situations where we had one little guy who actually was in Dr. Crawford's slideshow too, where he was just kind of fixated. We did his left side one day. I think we started with his right side. And the mom called me about 4 days later saying, he's moving his arm in front of him now for the first time ever. I said, well, bring him back in. Let's do the other side. Brought him back in. We did the other side. In 2 weeks, this kid, and the next thing you know, he's riding a bicycle. Now he was in a horse show a couple weeks ago. He got a ribbon in the horse show. He's holding himself appropriately for this. That's miraculous. And basically, hyaluronidase. The hyaluronan hypothesis is that where those dark patches are up on top, it just accumulates. And when you put the hyaluronidase in, you hydrolyze that hyaluronan, and then you let that muscle now be able to slide through that tendon. If the neurologic lesion that caused the dystonia in the first place is still there, it's not going to make that much of a difference. If the neurologic lesion has been able to be resolved, and you can now slide that, now kids who aren't moving can move. We don't ever know until you've tried it. The other part of that is, let's go to the next slide. Yeah, so the other element there is how well can you get into the area? You don't know how much hyaluronan's there, and you don't know how much it's going to take to break it down. So when people come back, we don't ever charge them for this. This is a totally experimental therapy that we're just collecting data on. And so if they want to do it 10 times, there's no harm in that. You can use 600 units at a time, body metabolizes it, and eventually we can get that broken up if, again, the neurological lesion isn't there. But if you've held your arm like so for 3 years, your brain forgets that this arm can do anything different. If you just hurt your leg and you limp for a couple weeks, at the end of that, you still want to limp, because this is the way that a nervous system accommodates and thinks this is the way things are. And so if you break it up and now they can move, now the neurologic lesion is getting sensory input from the organ. Now that changes the remodeling process. Now it gets back on the map. Now you might be able to do something with it. And so this is the last part, I promise. So another element in this process is often with hypoxia or anoxia, before your body will let tissue die, it'll let that tissue go dormant so that you don't use resources and it can maybe survive whatever the incident is. The problem is sometimes those cells don't wake back up again. And we play heck trying to get those cells to wake back up again. So there are things that are known as mitochondrial resuscitators. There's a compound called NAD that is a well-established mitochondrial resuscitator. We do it IV with people. I've done it for people that have drug addictions and substance abuse problems for a long time. It works pretty well for helping people get off of narcotics. However, it's not very, you can't put it in orally, and you can't sit there with an IV in a 3-year-old. You can, but it's not kind, because NAD going in an IV makes you feel anxious. Has anybody experienced that? Yeah, it's not fun. My football players are like, give it to me fast, because it's a macho thing. That's not good for you either. So we wanted to find a way that we could impart NAD to people and have it actually be intact and do the job that we wanted it to do, which is stimulate mitochondrial activity, wake up some of these tissues that were previously dormant. There are some peptides, one of which is called ISRIB, which is a whole nother conversation. And then I put NAD in a liposome, fed it to some people that I was giving IVs to, and said, how do you feel different? Do you feel the same? How is it? And did some blood values. Turns out a liposomal application works pretty well. So then we said, okay, well, let's create a base, and then we can add a lot of other things to it. And next one. Phosphatidylserine happens to be one of the most well-researched agents for helping to myelinate sheaths, nerve sheaths. When a person's having seizures, the nervous system isn't capable at that moment in time to carry the current that it needs to carry, so it spills across that structure into the adjacent structures, and that's what triggers seizures, tremors, aberrant nervous activity. Phosphatidylserine helps improve the myelin sheath function as an insulator and helps stop seizure activity and aberrant electrical activity. It's a phospholipid, so it becomes the base for the liposome. And let's go to the next one. So NAD and then some of NAD's precursors, NMN and NR, are all 3 mitochondrial resuscitators. We're waking up areas of a brain that were previously downregulated because of a hypoxic event. SAMe, 5-HTP, we don't always put those in, but for certain patients we will. We're just augmenting the production of some neurotransmitters. Specifically, we're trying to get some dopamine, we're trying to get some serotonin, and the SAMe acts as a methylator, which has an epigenetic effect to help regulate cell reproduction. And augmentine, which is at the very end of that list, which is a decarboxylated arginine. That's a whole nother conversation. But the point of it is it's a vasodilator, increases nitrous oxide activity, and reduces tone. So other things that we put in our liposomes, and these vary somewhat from patient to patient, but this is not an uncommon thing. You see that it starts becoming like a kitchen sink sort of a deal, or everything but the kitchen sink sort of a deal. However, over time, we've just found that these things are really helpful for dystonic situations, especially. And the next one. That's the last slide. That is Pinky, and she is being a hippo right now. She's really a pig, and that's my pond. She's the way that we end this slide, so. Thank you for your kind attention, and I apologize for being so long. If we have a minute, one of our mutual patients who's in California, is in the hospital. She has a sepsis, and I think she's going to be okay, but it's been nip and tuck. Her name is Riley, so if you have prayers available, please send them her way. And a very kind person has created a song for Riley that I think you will all find very poignant. And so I've asked David if after the end of this, if while we transition and go to the panel, if we could play that song. Thank you all very much.
You know me, Riley's Jerome. Riley's Jerome. Yeah, miss. You're so cute.
Hold me in your arms. Pull me close, 'cause I love you the most. Dance with me all night. Spin me round and round in you. I see the light. Trees and butterflies remind me of the life I have inside. I wanna be the best I can be. I find my strength when you are strong for me. I am happy when you're with me, and I am strong when you are strong for me. When you are strong for me, don't you forget. I don't have to fear as long as you're near. Families answered prayer. We've paved the road they said was never there. Darkness turns to light as we dance together every night. I wanna be the best I can be. I find my strength when you are strong for me. I am happy when you're with me, and I am strong when you are strong for me. When you are strong for me, and we'll be together. I'll always be a part of you. You'll always be a part of me. I wanna be the best I can be. I found my strength when you were strong for me, and I am happy